because you wouldn't know because you're across the Atlantic. So
Yes.
let's see. Sorry, let me take up this.
So this morning, our plan, if there's any issues with any of the speakers, do we just want to give them a few minutes and then see if we could just keep moving forward?
So your first speaker is here, and then I'll call Majid.
Okay.
Who's the third one?
Sherry.
Okay.
Yeah.
Sherry gave a video in case she couldn't make it. Sarah, have you been able to open her video?
Yes, I have it.
Okay. So you just go ahead and introduce Sherry as normal. But if she's
Okay.
not here physically, we'll play the video because in the video, she starts by thanking you for introducing her anyway.
Oh, okay. Alrighty. And we want to go with the full bios?
Yeah, you read it out, read them out.
Okay.
All their chieftaincy titles, everything.
Every last drop. Got it.
Every drop matters. Every heartbeat matters. If blood is life, why aren't we protecting it? This one's for the billions. They say anemia's routine, like it's just a little thing. But women and children suffer the hardest when the iron's running thin. Blood is a liquid organ, living, moving through our veins. We need care that heals the body, not a system causing pain. Iron, B12, folate, feed the blood, build it back, my body's fighting daily. I should get some credit for that, but I walk in the 7-1. 3 days later, I'm at 6, too many micro drugs could fix it. Why we still playing these tricks? My blood, your blood counts, our blood counts. Every drop of life is sacred, why they treat it earth don't count. Counts, your blood counts, our blood counts. Every drop of life is sacred, why they treat it like it don't count. Blood banks empty since COVID, can't keep living on transfusions. Bloodless medicine is safer. So why the same old solutions? My blood counts, your blood counts, our blood counts. We deserve care that heals, not just takes more out. Blood transfusion still the standard, though the science never proved better outcomes, better healing, or the quality we lose. But bloodless medicine is working, faster healing, lower risk. Respect the blood, protect the patient. That's the future we can't miss. Oh, we treat our blood with honor, build it strong from cell to cell. Give it oxygen and nutrients and it'll do its job well. But they draw more than we need and waste 90%. Tell me how that's good medicine when recovery's the intent. My counts, your blood counts, our blood counts. Every drop of blood is precious, why they acting like it don't blood counts, your blood counts, our blood counts. Every drop of blood is precious, why they acting like it don't count. We need science, we need choices, we need care that's evidence-based. Protect the blood inside our bodies, not replace what can be saved. My blood counts, your blood counts, our blood counts. We gotta do better, so we can feel better now. We're raising awareness for the billions who are fighting low hemoglobin, low energy, low vision, who smile through fatigue, who faint and get dizzy. But it's real, it's risky, this ain't routine, this ain't just busy. Treat our blood with respect, let the body restore. Test smarter, draw smaller, stop draining us more. We demand better outcomes, better care, better plans.
Are we ready?
Yes.
I'd like to welcome everyone to our 5th day of Bloodless Medicine and Surgery Week. Thank you so much for your support this week. It's been a fantastic week of speakers. Our panelists have all done a great job. This is such an exciting week for all of us. So thank you for that and being here. Just like to remind everyone that May is Bloodless Medicine and Surgery Awareness Month. Also, the Bloodless Medicine and Surgery Week in the month of May is meant to raise awareness about BMS as a superior form of healthcare. It is organized by the Bloodless Medicine and Surgery Group in the University of Calabar, Nigeria, in collaboration with Bloodless Medicine and Surgery BMSS, the Society for the Advancement of Patient Blood Management, SABM, and the Malaysian Society of Patient Blood Management as well, MyPBM. So the theme of BMSW 2026 is Principles and Practice of Transfusion-Free Haematology. I'd like to also introduce my co-moderator with me this morning or today, Dr. Oluwatomi Oyewo. Dr. Tomi is a consultant urologist, General Hospital, Ikorodu, Lagos, Nigeria. She is also a member of the Bloodless Medicine and Surgery Society, and we are so glad to have her today with us, moderating as well. Dr. Tomi, would you like to say a few words?
Yes, thank you, Sandy. Good morning, everyone. Thank you for joining us once again. It's been an exciting week so far. Just a few things to say about our housekeeping rules. Please, all questions should be placed in the Q&A. Would like to implore us to minimize our chats during the talk so we don't distract other attendees and speakers. It's also worthy of note to mention that this program is being streamed live on our Bloodless Medicine and Surgery YouTube channel. In case anyone has difficulty joining with the Zoom, the link will be in the chat box. And I welcome you all once again. Thank you very much, Sandy.
Thank you, Dr. Tomi. At this time, we would like to go into introducing our first speaker. This would be Dr. Afonime Essien. Dr. Afonime, her presentation will be the critical role of hematologists in bloodless medicine. Dr. Afonime Essien is a laboratory physician and a fellow of the National Postgraduate Medical College of Nigeria. She is a consultant hematologist in University of Calabar Teaching Hospital in Calabar, Nigeria. Her area of expertise is anemia management and sickle cell disease, in which she has published a local and international, or has been published in international journals. Dr. Essien is also a member of the National Cancer Technical Group in Nigeria. She is a sub-investigator to the GBT clinicals trials and was a co-investigator to the 54 gene research. She is ISO 18159 certified and Washington University Monitoring and Evaluation and Project Management certified. Dr. Essien is a member of several professional societies, including the College of Nigerian Pathologists and the Bloodless Medicine and Surgery Society. She is presently working on improving clinical outcomes of patients through the use of transfusion alternatives. We are so thankful to have you with us today. Dr. Essien, please, you go ahead and have the screen.
Thank you very much. Anybody see my slide?
Yes.
Okay. Please, on slideshow. Okay. Thank you very much. So I want to start to talk on the critical role of the hematologist in bloodless medicine. So I have no disclosure. These are my outlines, introduction, rationale for bloodless medicine, the pillars of bloodless medicine, who is a hematologist, the core roles of the hematologist, and conclusion. So as a form of introduction, bloodless medicine is practically management of patients without allogenic blood transfusion. And there's increasing global relevance of bloodless medicine. Why? Because of shortage of blood supply, the costs of blood, health basically is not cheap. So the adverse events of related with blood transfusion. So there's a lot of things that is discouraging people from going towards the blood transfusion route. So there's a global relevance of bloodless medicine. It is driven because of the safety that is involved, the ethics, and the patient preference. We're having a lot of patients that prefer bloodless medicine, not being transfused at all. So that's the way to go now. So why the rationale for bloodless medicine? Because of the risk involved with transfusion. We have the transfusion reactions, both the acute and the delayed. We have the transfusion infections. So there are a lot of infections that can be transmitted. We have the immunomodulation events. And as I said earlier, there's blood shortage, especially in a low resource setting. The cost and availability of blood is a problem. There are religious and personal beliefs involved with blood transfusion, and I've said the cost. Health is out of pocket in our environment. So when you think about trying to afford blood, and it's better to go the route of bloodless. So what are the pillars of bloodless medicine and surgery? We have been saying this all through the week: optimization of the hemoglobin, prevention of blood loss, minimize blood loss as much as possible, enhancement of the physiological tolerance of anemia, and optimization of tissue oxygenation. So all these are basically what the red blood cell does to transport oxygen. So when you do this, you are supplementing for the patient instead of giving the blood. So the question is, who is a hematologist? You have seen the picture of a lady, a beautiful lady looking at the microscope. So hematologists are both the clinicians and they're also the laboratory physicians. We make a lot of diagnoses looking at the microscope. We enjoy looking at the microscope. So we are specialists in blood disorders. We expertise in making diagnosis of anemia and treating them, the coagulation disorders, hemostasis. So we play a central role in bloodless medicine. We do in blood conservation strategies. These are the hematologists that forefront it. Optimization of erythropoiesis. How do we increase the hemoglobin or erythropoiesis without giving blood? So with the hematologists that's coming to the forefront of these goals. So the preoperative optimization, which is the foundation, is where the hematologists have the greatest impact. They say prevention is better than cure. So what we do, we screen. We try to screen for anemia before surgery. We make a diagnosis and we correct the anemia. We know that anemia is not a diagnosis. Anemia is not a diagnosis. Anemia is symptom. So you must try to find out the cause. There are different causes that can cause the anemia. So you must treat the cause, the underlying cause. It could be iron deficiency. It could be anemia of chronic disease, renal pathology, even hemoglobinopathies. Different things can cause anemia. So we're trying to identify the cause of it and treat. We use targeted therapies like iron supplementation, erythropoietin. And if it's a nutritional thing, you supplement. You can give iron replacements, the vitamin B12 and folate replacements to treat for the anemia before you take a patient in for surgery. So bloodless medicine applies for patients like blood management system. Like I said, you optimize the red cell management, which we have done. You reduce blood loss, phlebotomy, increasing withdrawal of blood for different tests or for things that are not necessary. Can we minimize that? Improve tolerance to the anemia through oxygenation and things like that. So what hematologists also do is we do risk stratification before a patient goes in for surgery. The sickle cell patient, those are prone to bleeding. We identify high-risk patients and we try to see how we can minimize the blood loss or optimize the hemoglobin before they go in for surgery. We develop individualized bloodless plan. There are patients that actually come and we develop plan for them before the surgery. We optimize them using the erythropoietin and the iron supplement before they go in for surgery. So in the intraoperative supports, the hematologist acts as a guide to hemostasis, both with the anesthetics and the surgeons. We act together to see how hemostasis can be achieved. We recommend pharmacological agents. We all know the tranexamic acid to reduce bleeding, or desmopressin to also reduce bleeding. We monitor coagulations. We interpret the lab results. Are the prothrombin time prolonged? Why are they prolonged? What do we do if they are prolonged? The activated partial thromboplastin time, what do we do? How do we manage this patient? We have a patient that has a prolonged international normalized ratio. What do we do? The fibrinogen. And so we try to interpret these results for the surgeons before they go in for surgery. And we rapidly correct coagulopathies without the plasma if it's possible. We also do a blood conservation technique. These are collaborating with both the surgeons, the anesthetics, and even the internists. So we try to see how do we conserve blood if they go in for surgery. What are the surgical procedures that will be done and how to conserve the blood. We advise the surgeon that, as I said earlier, on the active pneumovolumic hemodilution, the cell salvage method, which we have all been saying, if the patient accepts that, we do that. We control hypotension. For the post-operative management, that's the recovery phase, what the hematologist does is to keep monitoring this patient. We monitor the hemoglobin level after the surgery. If there's a downward trend, we intervene. We manage post-operative anemia. We continue with the iron and the erythropoietin therapy. We support the patient tolerance of anemia. We enhance oxygen delivery. We could use the volume status, we use the volume expanders. We give oxygen therapy, that's oxygenation. We monitor and detect any early complications. If there's going to be anemia, because the patient doesn't just drop after surgery. So you have to monitor to detect when there's a downward trend and intervene. So we can also detect if there's any occult bleeding. Is this patient hemolyzing? Is this patient losing blood from anywhere? We detect on time. We manage thrombosis, especially for patients that are immobilized or have a hypercoagulable state, like in sickle cell patient. So we can do the well score, both for the deep vein thrombosis or the pulmonary embolism. We can do the coronal score if it's a malignant patient. So these are things that will guide you on how to manage the patients if the patient has thrombosis. The patient at risk of having thrombosis, and you start early to intervene, being proactive. So management of bleeding in a patient are what also the hematologist does. We are experts in handling of coagulopathies, as I've said earlier, and this could either be congenital or acquired, which I've shown here. We can give non-blood product strategy, like factor concentrate, if the patient is having any of the factor deficiencies. Even the prothrombin complex concentrate can be given. The antifibrinolytic agent, which I've mentioned earlier, can be given. And the ways that you can give to enhance hemostasis so that the patient can stop bleeding. It's not just a bolus dose, but what do you do after giving the bolus and the patient is still bleeding? How do we do that? So the hematologists are in the forefront. So we also do with ethical, one of the roles that the hematologists also do is both the ethical and communication of this patient. So we have to respect the patient's autonomy. So the patient says he doesn't want blood, you respect that. You ensure that there's informed consent and there's documentation of this patient, so that any clinicians that see, any hematologists that see, know that this patient does not want blood, this is the patient's stand, and we respect that, and we try to increase the hematocrit for this patient with alternative way. We explain the risk of the anemia, which we are clinicians, we have to do that, and give the patient an informed consent, and the patient has an idea of what the risks are, versus if the patient is going for surgery or if it's a clinical patient. We also provide evidence-based alternative that is working and is effective for these patients that do not want blood. We also play a role in leadership. It's a multidisciplinary team. So for the bloodless medicine, for you to manage a patient that does not want blood, it is a multidisciplinary team effort. So it's not just the hematologist, but we are practically the head of the clinical head of that team. So we manage everybody, we coordinate, and we make sure that these patients doesn't want blood, and we raise the hematocrit. Both the surgeons, the anesthetists, the internists, the nurses, the pharmacy, we all come together as a team to raise the hematocrit of these patients. In terms of research, training, and policy developments, the hematologists are also in forefront. So we develop local guidelines for bloodless care. We also tailor it towards an individual. We have the individual care, or towards the environment we are. Each of us have guidelines. So we develop our guidelines to tailor towards our own institution and towards our own local context. We train clinicians. That's what we have been doing throughout this month of May, to train clinicians on the principle of bloodless medicine and the need that if a patient does not want blood, we don't need to force the patient, but we should find an alternative to raise the hematocrit for this patient. We audit the outcome, which we have found that some patients that are without blood transfusion tend to do better than those that have been transfused. And we also improve the safety. So it's a learning process also there. So we are involved in also some clinical scenarios, like in the obstetrics, those that have postpartum management, hemorrhage. For the women, the hematologists are called, which we try to stop the bleeding and also raise the hematocrit for these women. For the oncology cases, we support care for chemotherapy-induced anemia. So we found out that before the chemotherapy, we try to raise the hematocrit for these patients. We give supportive treatments, the growth factors for the patients before chemotherapy, because knowing that most chemotherapy are myelosuppressive, and so during the events of the chemotherapy, blood lines will be reduced. So when you optimize the patient will not need blood at the end. So even in cardiac surgery, there are high-risk blood conservative protocols, which we bring out protocols to minimize blood, optimize the patient before they go in for surgery. So in conclusion, the hematologist is indispensable in the care of bloodless medicine, and they play a significant role to improve the safety while reducing reliance on transfusion. Bloodless medicine is not simply avoiding blood. It is evidence-based optimization of patients' own blood and physiology. So hematologists remain central in achieving this goal through a multidisciplinary leadership, through scientific expertise and patient-centered care. The important thing is that this is a patient-centered care. So it's an individual treatment. Each patient don't have the same thing. We might all do the iron and the erythropoietin, but how do we administer? The dosage that we administer, they are all dependent on the individual. So that's why it's individualized care of these patients. So I acknowledge the Society of Advanced Patient Blood Management team, acknowledge the management of the patient blood management team orthopedic, the Society of Thoracic Surgeons, the Malaysian Blood Management Society, and Dr. Osoro, MD. So thank you very much.
Thank you so very much, Dr. Essien, for your talk. Quite brilliant and smooth delivery. And I have the pleasure to introduce our next speaker, the person of Dr. Majid Raphael. Dr. Raphael is a professor of pathology and laboratory medicine at the University of Rochester Medical Center in Rochester, New York. At Strong Memorial Hospital, he serves as the director of the Thrombosis and Hemostasis Lab and the director of their blood bank / transfusion medicine department, and also the clinical laboratory department. He also holds an appointment as an associate director of the therapeutic apheresis unit in the internal medicine hematology department. Dr. Rafai is also the medical director of a 2 CSL Plasma Center in upstate New York. He received his medical degree from the Aleppo University of Medicine in Syria, subsequently joined Massachusetts General Hospital, Harvard Medical School in Boston as a research fellow in a special coagulation research lab. He completed his residency in clinical pathology at the Washington University School of Medicine in St. Louis, MO, and held a fellowship in transfusion medicine at the University of Texas, Southwestern in Dallas. His research focuses on the in vitro and in vivo effects of ABO antibodies and ABO immunocomplexes on platelet function, coagulation processes, and endothelial cell integrity. Dr. Rafai is also working on developing a platelet microparticle lysate that can be used to control bleeding. This product has been patented. Another patent that Dr. Rafai is developing currently is an ABO point-of-care testing device. We warmly have the honor of having you in our midst today. We look forward to your presentation. Please go ahead, Dr. J.
Thank you, Dr. Oye, for this nice introduction. And let me share my screen here. Okay, Dr. Oye, can you see my screen?
Yes, please.
Okay. Okay, so good morning, good afternoon, everyone. And thanks for having me here. Thanks for inviting me to give this talk. So today I'm going to be talking about some clotting disorders and how can we manage these without the yellow part, without the plasma. So these are my disclosures. I serve on advisory board for some companies, and I receive some consulting fees. And
Respect yourself. Yeah, senior man. Hey, I don't know whether they have this. Make I read
Could
the
you mute your mic, please?
good day, volunteer.
Please mute. Please go ahead, Dr. Majid.
sorry about this. Okay, so here are my objectives for this talk. Understanding the risk of plasma transfusion, recognize the inappropriate indications, and identify safer alternatives for the plasma, and also apply some evidence-based transfusion strategies to avoid this. So I'm going to start with this case. Patient with INR of 1.8 has no bleeding, scheduled in interventional radiology to place a central line. Unfortunately, two plasma were ordered and given, and the patients developed transfusion-associated circulatory overload after these two plasmas. So the question here was this necessary? Could this harm be avoided and prevented by just not correcting this a little bit of prolongation of the INR? And we'll talk about the INR later on. So first, let me start with introducing what is fresh frozen plasma. So as you know, plasma separated from the whole blood unit when they get collected from donors, and it's frozen within 6 to 8 hours at minus 18 degrees centigrade, and that's what will be known as fresh frozen plasma, because we're maintaining all the coagulation factors close to 100%. Once it's stored, can be used up to 12 months. As I said, it contains all the coagulation factors, and some other proteins very important are albumin and immunoglobulins. The typical dose or the suggested dose is about 10 to 15 ml per kg in an adult patient. But there are some other products also of the plasma. We have what's called frozen plasma, which is a plasma that's where we're not able to separate and freeze within 8 hours. And that's called frozen plasma, not fresh, frozen plasma 24, which was stored after 8 hours and up until 24 hours. The only things significant in this unit is they have less factor 5. They have much lower factor 5. Some references, they go up to 50% drop in factor 5. The other product we have, it's called thawed plasma. Thawed plasma is once you thawed the FFP unit and you said, let's say you did not use within the next 24 hours, it was allowed to save these units in a fridge. Wasn't there before, but just like maybe in the last 10 years or so, it was allowed to save these units in a fridge, and you can use it up to 5 days. So that would extend the lifespan of the fresh frozen plasma. The problem with these plasmas, they are low on factor 5 again, factor 8, and protein S. And I'm very sure nobody is using this to replace these factors, but just to be aware what exactly the difference is between different types of plasma. Then we have something called liquid plasma, and this has never been frozen. The minute it's been collected, it's just stored at the fridge. And again, they are low in these 3 factors. So I just want to touch base on a little bit of some ignored fact about plasma. As you know, it's about 50 to 60%, could be a little bit 65% of the total blood volume in our body. They serve as a transporter of the proteins, nutrients, hormones, you name it. But you have to keep in mind that plasma is about 90 to 95% of water. So when I'm transfusing someone 2 to 3 or 4 or 5 units of plasma, I'm filling up him with water, basically. So just keep this in mind because the protein is only 5 to 10%. And each unit contains about close to a quarter of a liter. So within 3 to 4, I'm basically putting almost 950 to 970 ml of water in these patients. How good this could be. So does FFP correct coagulation factors? Yes, from the NIH library, FFP does correct the coagulopathy and does supply plasma proteins. But look at this. In the absence of any bleeding or DIC, so you have to keep in mind there's no bleeding and no DIC, a standard dose of plasma, about 10 to 20 or 10 to 15, could be 4 to 6 units in an adult. Here we go. So 1 to 1.5 liter in order for me to correct factors in a factor deficiency patient. And after all those 4 to 6 units of the plasma, I just raised up the factors by about 10 to 20% because it's been very well known that each unit of plasma can rise up factors by about 2 to 3%, 2.5% in some references as well in an adult patient. So each unit is going to correct me, like let's say I have factor 7 of 30. If I give him 1 unit, that's going to be 32.5 or 33. So it's very negligent amount of increase per unit of the plasma. So why we were using plasma? Because in the past, it was the only source of coagulation factors. And we used it in a lot of different conditions. Number one, and we still use it until now, in a very severe bleeding or very acute trauma patients. We used to use it in warfarin reversal when the patient has a very high INR. We still use it at sometimes. Unfortunately, some centers, they don't have the concentrated factors, so we still use plasma at some point. We use it in liver disease. We used to use it a lot and still been used. TTP is kind of considered maybe until now it's the gold standard by the plasma exchange. And we could definitely use it in any clotting factors that we don't have concentrated factors for them. So on all the cases, any coagulopathy could be corrected with plasma. But you have, as I said in the previous slides, you have to give a lot of plasma to correct that. So the core problem with plasma or plasma transfusion is correcting abnormal labs. This should not be number one on our treatment or on our goal. And a lot of times they use it to prepare for a procedure, just like what we saw with our patient. Placing a line, they did not like the INR 1.8, and they wanted to give him plasma, and they gave him 2 plasmas. The things that people do not really connect very well, or there's a disconnection, is looking for the lab normalization. Why do I have to have my patient, who is a patient in a hospital, to be 100% perfect with a normal normal levels of my labs, especially INR in this case? And definitely not a lot of people paying attention to the clinical outcomes. There's a lot of reactions sometimes happen because of the transfusion of the plasma, but nobody link the outcome with the transfusion. They just take it in their mind that transfusion is safe. So some of the reactions of the plasma, trolley and taco are the number 1 and number 2 very common reactions in plasma transfusion. We do have allergic reactions. We do have some infection risk, although it's not very high with plasma, but it could happen. And we do have some immunologic effects. So let's just focus on one of could be like a very fatal reaction in transfusion and associated with plasma transfusion. It's called trolley or transfusion-related acute lung injury. It could happen up within 6 hours of the blood product transfusion. Not necessarily plasma, could happen with any blood products. It's a little bit more common in plasma, and we're going to say why when we see the methodology of it. It caused non-cardiogenic pulmonary edema, definitely associated with hypoxemia and infiltration, bilateral infiltrations of the lung tissue. Mortality is very high, could reach up to 25% in some references. And it's the most unreported reaction. They just don't link the trolley or the acute lung injury to the transfusion. A lot of misreported, and a lot of physicians, they just don't think about it that's related to transfusion. This is just an X-ray of somebody who has trolley recently, and you can look at how destructed is the lung tissue, because it does destroy the lung tissue itself, as we're going to see later on by the methodology. I found this article as a review article of the trolley, and I couldn't believe it that in some cases there's some trolley, what they called it late trolley, up to 72 hours. I mean, I was under the impression, with all my experience of transfusion medicine practice, that it's about in the 6 hours, that's what we call trolley. But they were able to find in this review that similar criteria of the trolley could be even present up to 72 hours, and they define it as a late trolley. So just to keep this in mind, don't ignore it even if it's after the 6 hours. So what's the methodology of trolley? We are transfusion. This is the most common kind of like methodology. There's a couple of theories, but this is the most common accepted one. Is my plasma or my blood product hence has some antibodies to it. Those antibodies are directed toward the white blood cells, toward monocytes. And that will activate the monocytes to release, that will activate the monocytes to release some inflammatory mediators, inflammatory protein molecules. Those will activate more of the neutrophils, which will bind to the endothelial cells and causing damage to the endothelial cells, and then cause the permeability of these tissue where the edema is going to happen in the lung tissue. So I'm destroying the endothelial cells here of these lung vesicles. So that's what's the trolley methodology is. And that's what we see. It's not like the TACO, which we're going to describe after this one, but in this case, it will take time to rebuild this tissue. And that's why the fatality is very high in this disorder. So why does it matter? It's very difficult to predict. It has a very high rate, as we said, of the morbidity and mortality. There's no specific treatment, and if you also did not manage it very well, or you did not think about it very well, you could harm the patients. Like imagine a trolley, give them some diuretics, you will concentrate the effect and the damage of these inflammatory mediators on the endothelial cells of the lung tissue, and that could even cause more damage. And most of these cases, I haven't seen any case like this that does not need an ICU level of care, which could be for several days if the patient survives. The other important reaction with plasma is transfusion-associated circulatory overload, or known as TACO. So it's basically just when I give someone extra fluid, you just imagine you have in your body, you have only one empty space where you have air, which is lungs. When I give you extra fluid, where is it going to go? It's the only option for it is to fill up this air space, which is in your lung. And that's what happened with with TACO. It's basically I'm overloading you with volume that will cause some dyspnea, some hypertension, and elevated of the PMP. Who's at risk of TACO? Elderly patients, most likely. Heart failures, patient, any renal impairment, they cannot manage the fluid right away, and very critically ill patients, and in patients who could be having already some lungs issue or some SLP to start with. This is just the differentiation between trolley and TACO. As you see in this case, it's a permeability edema. You already damaged the tissue here, versus over here, you just causing more hydrostatic edema, where you just put more volume in the empty air. There are good things about it, and it's not always there, but in these cases, usually you have hypotension and fever associated with Raleigh, and you definitely will have a normal GV pressure. Versus in some in TACO, you will have elevated jugular vein pressure, you have tachycardia, and you will have hypertension. So these, I mean, not 100% all the time available there, but I would pay attention to these. Other complications of the plasma, I mean, we all aware of the allergic reactions. Some of them could be severe. In very rare conditions, could be anaphylactic. There is, as I said, infection risk, although it's low, but not zero. And there is some transfusion-related immunomodulation, which is TRIM. I'm not going to discuss this today. Why do we have this misconception of I have to correct INR? I have to fix INR before I do my procedure. A lot of physicians, they afraid of elevated INR more than any other screening coag tests. I mean, I'm very sure you guys practice medicine and you are aware of the lab results, but I could give you a normal INR on a hemophilia patient. I could give you a normal INR on a vulnerable patient. Even mild vulnerable patients maybe never have any bleeding, or maybe he has bleeding, but as you know, reporting bleeding is very subjective to every patient. He may like drop a couple of drops from his blood and go to the ED because of it. And some people may bleed half a liter and it's considered nothing. It's normal. So you could miss a lot of patients by just doing INR and not paying attention to, number one, clinical findings, patient's history, and some other screening lab test, not only INR. Unfortunately, I see a lot of surgeons, they depend only on one test for their assessment of any bleeding risk or any clotting risk, only on one test, which is INR. And I'm going to tell you why this test is wrong. Now, not only this, they want to correct it. Not only they are testing for it, but they want to correct it. And as we saw in that case, just to place a line, they transfuse him with 2 units of plasma. So INR in the patients, when we establish the normal INR, we take normal individuals. We take like between maybe ages of 18 to 60. But in elderly by itself, INR could be prolonged more higher than the normal population range, because most of those 18 to 60, if I'm taking my medical school or my lab staff to establish a normal INR in my lab, those average age will even switch down. Although the range is 18 to 60, it could be more toward the 40s to 50s. Because most of them students, techs, lab techs who just started. So you have a lot who will be interested to give their blood for 10 or 20 bucks to establish the normal range. So when I have someone who's 1.4, 1.5, and he's 70 or 80 years old, that doesn't mean he's abnormal. Any antibiotic therapy, any vitamin K deficiency, any not eating vegetables for a few days could cause abnormal INR. We have a study, data collected for a study that after putting a patient in ICU for 3 to 4 days, his INR goes up by itself automatically. You know, so that's just paying attention to these. Don't too much strict to the INR. And why? This is very important here. I'm going to show you that the relation between the coagulation factor concentrations and the PT, or what we calculate from it, INR, is not a straight relationship. It's not a very straight line, okay? It doesn't mean that every increase in the coagulation factors will improve my INR accordingly. It doesn't mean that every FFP I'm giving is going to reduce my INR by 2 or 3 degrees. No. The normalization of the INR need much more plasma when you are in the very low numbers, okay? Versus if you are in the high numbers. Yes, in the high numbers, it may help. Here, it definitely it will help. If I can bring the patients from 3 to maybe 2.3 or 2.4, maybe with a couple of plasmas. But in order for me to correct these patients to here, to the normal level, or the 1.5 they always ask for, I would need 5 to 6 units of plasma. So yes, I'm correcting INR, but I'm putting these patients in the ICU because of the trolley or TACO. Okay, at least TACO. When you get to a higher numbers, yes, one plasma will you'll need more plasmas just to fix a little bit of the numbers, because as I said, the correlation in here is not a direct correlation. Okay, and that's the nonlinear correlation between the coagulation factors and the INR level. It's what's causing this issue here. So that's what we have to keep in mind. What are the other areas where we use plasma, and we still use it very heavily in liver diseases? And again, depending on some abnormalities in INR and some high risk of bleeding, because now the abnormal INR, it could make me think that my liver patient is going to bleed, but that's not right. Why? Because the liver patients, they have a normal called rebalance hemostasis. They will rebalance themselves by a special hemostasis level for these liver patients. Yes, we cannot come up with a reference range just for liver patients because everybody is different, but you don't have to panic when you see a liver patient with a very high INR. They're actually at high risk for thrombosis sometimes, not only bleeding. Okay, so patients with liver disease acquired complex alteration in their hemostatic system that may lead to abnormalities and abnormal test results, but these test results in some cases could be actually high risk for hypercoagulable state, not only hypocoagulable states. And some patients actually with liver disease, they could form thrombosis. So this is the normal balance of the hemostasis. You are usually here. Bleeders will be more toward bleeding versus more toward thrombosis if they are clotter or hypercoag. The liver patients, they are exactly the same, but with less factors. Okay, so they still balancing themselves, because as I said, you will lose the coagulation factors and you will lose the anticoagulants as well at the same level. So this is just to show you that's why the rebalancing is happening, which could be sometimes promoting bleeding versus sometimes promoting thrombosis. You can see here for yourself, there's a lot of factors that could affect it and participate in the rebalancing of the liver failure, the liver patients. So my point here, I'm not going to go through this very well. It's going to be available online if you want to go through it, guys. But my point here is don't panic when you see abnormal INR in a liver patient. So the suggestion by ISTH that yes, prophylactic correction of some, I'm sorry, that paper was from the ISTH guidelines for the liver patients correction of their labs. So the prophylactic correction of some lab results, abnormal lab results in liver patients most likely is not indicated. You don't have to worry about it and correct it really very quickly. Sometimes actually you have to think about thromboprophylaxis in these patients because they may form clots. Okay, so some considerations of the plasma usage that's often given in central line placements or some biopsies, but there's a lot of evidence show that these cases, just by central line placement or biopsy, they associate with a very low bleeding risk, and correction is not needed at sometimes. A lot of cases it's not indicated. So when plasma is appropriate, when can we use plasma? I'm not saying this just because I'm an anti-plasma and it never should be used. No, we could still use plasma, but it should be when it's appropriate and beneficial to the patients. Again, as I said, in massive hemorrhage, as in trauma or in accidents, in the DIC with the bleeding, not like DIC with no bleeding, FFP won't be good. Actually, to keep in mind, that's to go back to the water, 95% of the plasma is water. When I'm giving someone plasma just to correct his coagulation factors, think about what you did to the platelets. You are diluting the platelets. You are increasing the pressure inside the vessels, which will cause problematic and constrictions of these vessels that's needed to stop the bleeding. Number one of the stop the bleeding in normal hemostasis is constricting the vessels. So I'm adding more water to extend this levels. So I'm actually increasing the risk for bleeding, and I'm reducing the process of the normal hemostasis. Yes, we can use it in TTB, as I said, and sometimes in severe factor deficiencies where, as I said before, when we don't have concentrated coagulation factors for these. So what about the future? What should we do? Okay, Dr. Rafai, tell me not to use plasma in my hospital or my lab. What should I do? We can use something called replacement factors, concentrated factors. Prothrombin complex concentrate is very sufficient to replace the factors missing, which is the vitamin K factors. Those are the most factors affecting INR to start with, because factor 7 is with them, and only factor 7 affecting INR, by the way. Forget about all the other factors. So this is very quick reversal of the warfarin, small volume and faster administration. I don't have to take a long time, safer, much less complications, and much shorter stay in a hospital or in the ICU. We published this paper from the K-Centra study that was done in USA here, and we show how the increased volume overload with plasma comparing to the PCC. And as you can see here, the differences in correcting INR in these patients, how much volume we give them in the plasma arm versus how much volume we give them in the 4-PCC factors, concentrated factors. Although we do have, definitely we have some over volume, over fluid here, I mean, the overload, I'm sorry. We did have some overload in the PCC arm, but trust me, those were not because of the 100 or 110 cc I gave in my concentrated factors here. But the problem is, since they are an arm and they receive blood or they receive platelets or they receive fluid to start with in the trauma patients or in the bleeding patients, that's caused the increase in volume overload in this group. But we have to report it just because it was a randomized control trial. So factor concentrates, again, it's very disease specific. Like if I'm looking for a specific factor like 8 or 9, those very directed toward the disorder. For fibrinogen concentrate, for example, very directed for the factor, for the fibrinogen deficiencies or invulnerable factor as well. The benefits of these alternatives is lower risk of Trali and Tanco to almost zero, okay? Rapid action, predictable dosing, and less fluid overload, and much faster time of application. What else I can use? Point of care testing. We know that's the viscoelastic testing, TEG, Rotam, or Quanta right now in the market. All of these three viscoelastic testing right now could help me avoid a lot of unnecessary transfusion to start with. Not only plasma, we're talking everything's here. So it will give me a real-time the clot formation analysis, which telling me and identifying to me what exactly is missing. What could be the differences between the abnormal traces I'm getting? Is it a factor deficiency? Is it a platelet? Should I don't think that if you're giving plasma and he has a platelet dysfunction, you're gonna help. Actually, you're gonna destroy further because the platelet now is diluted and less effective of their function. So see how my viscoelastic testing will help me identify the most important factor that could help my patients and help managing their bleeding. So yeah, so it will guide my therapy a little bit much better. So in general, what are the strategies to reduce plasma? Education. Because as I said, a lot of physicians, even surgeons, they think that's the only magic product that could help my patients and fixes INR is plasma. The only magic could reduce my bleeding risk in my patient is blood products. No, let the blood products be the last resort. Okay, you don't call the pharmacy to get a medication just because you think that's an extra dose or an extra medication, or this medication which is not indicated for every single condition will help my patient. So try just to stick to do not transfuse. Make your transfusion as a last resort. And that's only by us, by transfusion people or lab people, or in general hematologists as well. We need to educate and make all of the other physicians and all of the other members of the hospital and the health system aware of when and when not to use blood products. So adjust or modify your protocols, your policies in the hospital. That will also help. Focus on alternatives, as we discussed, and always has some feedback and some audits. So to take away messages, plasma transfusion carries real risk, often overused for lab abnormalities. Don't do that. Don't use it just to fix lab results. Alternatives are safer and more effective, and the clinical concept must guide the decisions, not the lab results. In conclusion, doing without the yellow is a smarter care, shift toward evidence, toward precision, toward patient-central decisions. And with that, I'll finish my talk, and thank you very much.
Dr. Rafai, thank you so much. That was excellent.
Thank you.
Very informative, yes, and so much to learn. I really appreciated the questions you asked in the beginning. Very insightful questions. The whys are so important, and that nobody's perfect, including our patients.
Yep.
And so we don't want to focus too much on those numbers, but rather on the patient and using alternatives. So thank you so much for that.
Thank you.
I do want to take a moment and introduce myself before I go into the next part of our session. My name is Sandra Mann. I've been a nurse for 26 years. My early beginnings with patient blood management and bloodless care began way back in 2011 with ProMedica Health Systems out of Flower Hospital, Sylvania, Toledo, in Ohio. I was also part of SABM at the time, and that was so informative. I learned so much. I really cut my teeth on that. Currently, I am in Fort Smith, Arkansas. There is no PBM here. We are still pioneering that, and hopefully that will change one of these days. I am so privileged to be a part of and involved with BMSS as a general secretary currently, and really go back with Nathaniel, Dr. Osoro, way back to my early beginnings. So we've all seen so many changes for the better and continue. So we are so excited for these changes. So one of the things we do not want to forget, though, is the history, where we've come from, how far we've come. And so that actually segues into our next part here, and that is introducing our last talk, the recent feature that we have added to our BMSW week. That is entitled Heroes of Bloodless Medicine. So we first presented this last year at our BMSW 2025 week. Sarah Walbolt, a nurse that has worked with us for many years now and is also very well known in our global community here, featured that. You can find her on YouTube for last year's session if you missed that. However, this was so successful that we will now make this a regular feature of the week every year, just to give due credit to the past heroes of bloodless medicine and surgery. So this year we are featuring Dr. Denton Cooley. He was the father of modern bloodless surgery. And this will be presented by Sherry Ozawa, RN MSN, on her talk, Heroes of Bloodless Surgery, Dr. Denton Cooley, MD. And I'd like to just give a brief bio on Sherry, although for many of us, she is very well known now and highly regarded. But Sherry Ozawa has been globally recognized in patient blood management and bloodless medicine and surgery for over 2 decades now, with a strong background in nursing critical care She also played a pivotal role in developing and leading one of the world's most successful and widely recognized multidisciplinary bloodless and PBM programs at Inglewood Health in New Jersey, USA. Sherry holds both undergraduate and master's degrees in nursing with a focus on healthcare administration. She is much sought after as a lecturer across the United States and internationally now, specializing in creation and implementation of sustainable, organized PBM programs, as well as the promotion of the concept of blood health to both professionals and to the public. Her expertise is reflected in numerous peer-reviewed abstracts, posters, book chapters, and articles, and she remains actively engaged in the research in the field as well. Beyond academia, Sherry has collaborated extensively with regulatory bodies and practices in PBM program development and implementation. She has also served as an expert consultant for numerous medical and public media outlets. As an investigator on the first U.S. federal government grant funded by the Department of Defense, she contributed to the creation of a structured training program for physicians and healthcare professionals in PBM. Additionally, she was a founding member and past president of the Society for the Advancement of Patient Blood Management, an international multidisciplinary medical society dedicated to optimizing PBM practices. She is also a member of the Bloodless Medicine and Surgery Society and received the Award of Excellence of the Society in 2019 for her excellence and contribution to the science and practices of patient bloodless medicine and surgery. Currently, Sherry serves as Director of Comprehensive Patient Blood Management Delivery and Operations at HC1, a US-based company specializing in implementing patient blood management programs nationwide. She also advises bloodless and patient blood management programs globally, and she was selected as the only nurse contributor to the World Health Organization's Patient Blood Management Implementation Panel. Sherry, you have accomplished so much. We are always so privileged and honored to have you here with us. And at this time, you have the floor. Thank you.
Thank you for the introduction. It's my pleasure to be with you here on the second to last day of activity during our Bloodless Medicine and Surgery Week 2026. Please excuse my voice today. I have a bit of a cold, but it is my privilege to be here along with so many esteemed friends and colleagues presenting. We've all learned a lot this week and been inspired by the work of so many people from the past and the present and valves and artificial heart. Artificial heart implantation, but his legacy really extends far beyond those milestones into what we now know as bloodless medicine and surgery and the understanding of and focus on human physiology. And it's with his work that really the mindset started to change from an absolute reliance on the blood bank to the ability of the body's own liquid organ, blood, to regenerate itself in an amazing, amazing way. So a little bit about Dr. Cooley's history. He worked, of course, alongside other amazing pioneers. We don't have time to talk about everybody, but in cardiovascular surgery, like Dr. Blaylock, Dr. Thomas, Russell Brock. He also did his time in the Army, serving in Austria, but a little bit more about him. He was a zoology major at the University of Texas at Austin. He was also a basketball player. If you ever got to see or meet him in person, he was quite tall. and what I think contributed even more to his amazing mechanical and medical and mental ability, being a bass player in a swing band. So he went back to Houston after his time in the Army in the 1950s. He worked alongside another legend, of course, in cardiothoracic surgery, Dr. DeBakey, on aortic aneurysms, and then founded the Texas Heart Institute about a decade later, in 1962, something still in place, an amazingly esteemed institution here in the United States. It still remains a global destination, certainly for patients and for amazing patient care in cardiothoracic surgery, but also for constant innovation, which they still lead the world with today. So probably what he's best known for in the popular mindset, this amazing milestone in the implantation of the artificial heart back in 1969, 1970. Amazing feat of science that he was known for. But this, along with the other mechanical advances in valves, etc., really did an amazing job in slashing surgical mortality. So during this 5-year window that you see here in the mid 1960s, you can see this survival rate, or I should say the mortality rate, plummeted from this, of course, incredibly complex surgery, which we still know is open heart surgery or cardiothoracic surgery. And keeping in mind that we've still made progress, right, with all kinds of different techniques and methodologies that utilize minimally invasive surgery and other management techniques for patients' blood. But at that time, many of these things were still being developed. So this was really revolutionary that they were able to impact surgical mortality. But let's think for a moment in the historical context of the world and the mindset in which Dr. Cooley worked after this experience in World War II. The context and the mindset in the medical world and the public to some degree too, of course, even at that time, was that transfusion appeared in large scale in battlefield medicine. It was able to be stored. It was able to be transported. There was a way to fractionate it into its components. It was started to be perceived as this incredible medical miracle to be able to use human blood for what was perceived as life-saving purposes. And this message of blood saves lives still lives with us today, right, all over the world, in whatever language it is. This concept that the transfusion of blood is a life-saving therapy, and the donation of blood is this ultimate expression of human altruism or community service or even patriotism. So what was the reality then, right? This was not just about medicine. This grew into an industry. So blood collection grew into something far beyond just what was happening on the battlefield, a global medical industry, which still, of course, lives large today. And this broke outside of military use into civilian use. So the services of the blood industry were aggressively marketed to hospitals and health systems around the world, of course, still happening today. And the public, medical providers, surgical providers, government systems assumed that transfusion was universally safe. So, of course, all over the world, there are regulatory agencies and countries that look at the safety and efficacy of devices and therapies and drugs, things that we put in and on patients to establish both safety and efficacy, or create a safety and efficacy profile. What many are surprised to learn is that transfusion of blood components as we now still know them today, never went through that rigorous process. Here in the United States, it's the Food and Drug Administration. Other countries have their own regulatory agencies, but blood was not subjected to the same level of scrutiny that all these other therapies are. It was on a fast track into the hands of medical providers and into the minds of the public as this incredibly miraculous life-saving therapy. Now back to the world that Dr. Cooley was working in open heart surgery, historically inherently relied on massive volumes of transfused blood. And I think this was really an interesting statistic that in the 1950s, up to 12 units of blood were required just to prime the heart-lung machine before surgery even began. And we know that's entirely different today, but the concept for anyone in those years and those decades to possibly perform successful open heart surgery without not just a little donor blood for transfusion, but quite a bit, seemed impossible. But Dr. Cooley had a very different view of how we could optimize our patients and not just have this reliance on donor blood, no matter how it was perceived. He had a higher vision, or a much more forward-thinking vision, that by optimizing our patients' blood preoperatively, reducing blood loss during surgical procedures, and also tolerating lower levels of hemoglobin while we don't just stand around and watch, but while we help support the body in regenerating this amazing liquid organ. So it's now, of course, what we recognize as the pillars of patient blood management, the heart and core of bloodless medicine and surgery. And this was his vision, and we'll hear more about things in his own words in a little while, how he saw this. So, of course, he was not only an incredibly skillful surgeon and amazing man, but he also had a strong ethical view of the rights of patients to make choices for themselves. So when the community of Jehovah's Witness patients came to have, unfortunately, some conflict with this, with the medical community in some places, with this growing availability of donor blood, they were presented with the challenges of finding adequate care. So Dr. Cooley took that challenge on, as we know, in the 1960s, performing bloodless surgeries on patients for whom transfusion was not an option. But he was at really the forefront of driving a change, what we now know has dramatically positively impacted patients across the world and well beyond cardiothoracic surgery. So he did not give these patients a lower standard of care. He actually, we know now, gave them a higher standard of care, which is what we would call modern bloodless medicine and surgery. So keeping in mind this paradigm shift, now he didn't use these words, but we could see it in retrospect now very clearly, but that local innovation really catalyzed this paradigm shift. So this post-World War II world that he lived in and he worked in, where blood product was a default, transfusion was a standard protocol, everyone assumed that blood was life-saving. There was a big reliance on this external supply, but people didn't really think much about its availability, its cost, its vulnerability to pathogens. It was just something that was the default. But what he saw as this new way of thinking was focusing, again, not on this blood bank blood, but on the patient's own physiology by minimizing loss and optimizing our tolerance, right? As a medical community, if the patient was stabilized and supported, they could regenerate, in many cases, very well, their own liquid organ. And for some patients, transfusion certainly was an option that he took care of, but it was not seen as the default position, right? So for some patients, it's never an option. For some patients, clinically, it may have been considered so, but never the first thing to turn to. And what do we see as a result of a whole new way of thinking? Now, Dr. Cooley did not have the medical literature that we have available to us today, which looks very carefully about outcomes related to transfusion across many surgical populations, medical populations. We know that it leads to poorer outcomes, right? Increased morbidity, mortality, etc. He didn't have all that literature, but he saw the vision that still this was the right thing to do. And of course, now we have many decades of science that tell us that this helped patients around the world, this lack of reliance or reduction in reliance on this, this dangerous product. So, of course, another big milestone, an unfortunate milestone during the 1980s, this product that was perceived as universally safe had a very different profile. Of course, HIV appeared and AIDS to follow as the resulting disease in the blood supply. And there was a pause, not just for one religious group, but because people all over the world, the medical community and the public saw the vulnerability, right, of this pathogenic contamination of the blood supply. This was identified, but it really caused, unfortunately at that time, somewhat of a temporary pause, but in the way that blood was used, at least for many people's minds, an opening of the thinking, but at the very least, the vulnerability, right, of the blood supply was exposed. And still to this day, just last year in the UK and other countries in the world are still having hearings and documenting some of the choices and decisions made by government systems and health authorities and clinicians around this activity. Unfortunately, of course, many people became sick and lost their lives because of some of those decisions and because of that process. So it was an unfortunate way to have this vulnerability exposed, but again, the historical context was we learned something from that, we the greater medical world. So this was amazing. We learned about Dr. Cooley's amazing legacy, what he did for cardiothoracic surgery in terms of mechanical work, etc. But how did he perceive his own life's work? So really an interesting quote out of his memoir, that he felt that his bloodless surgery technique might have been his most important contribution to open heart surgery. So perhaps in the greater consciousness, it's not what he's most remembered for, but he personally saw this as this incredible personal, ethical, scientific milestone. And indeed, we certainly can see today and every day more and more that it absolutely was in the way that he saw things. So he really, fortunately, started what we hope to call a revolution, or what we do call a revolution. And he proved that by measuring this in many patients, hundreds and hundreds of patients. And again, he was joined by others, some of the names you see on the screen over the course of time. 1,200 surgeries by Dr. Cooley directly and his team. Of course, we know further progress this field of overall betterment in cardiothoracic surgery, certainly advances in bloodless medicine and surgery, and what we now know is important for all patients with this patient blood management. So other folks, he wasn't alone, but it was, of course, still a slow start, and we still have work to do around the world. So I will also mention, and we must mention our other grandfather, great-grandfather, I think, here in this field, where Dr. Isbister in 1988, after Dr. Cooley did much of his work and writing, coined this term patient blood management, which a similar philosophy, this paradigm shift, but he put a name to it, where it was this shift from the product in the blood bank to the patient. Dr. Isbister, of course, was a hematologist, so we would hope that hematologists fundamentally shifted their clinical vocabulary. I would say we still have some work to do here. Certainly, we've had lots of progress, and this is not meant to put down any of our hematology wonderful colleagues on this call or anywhere else, but we have more mind shifting to do. Dr. Isbister, of course, was another pioneering thinking, aligned with Dr. Cooley's thinking, but we still have miles to go to get all, not just hematologists, but both our clinical colleagues as well as the public, to think about really the patient-centeredness and optimizing our bodies and protecting our body's own liquid organ. So a couple of milestones, some of this history you already know. Several organizations were formed there. I can't list them all anymore on a single slide. Society for the Advancement of Blood Management, it was called then. Now, of course, it's called Patient Blood Management. Australasian Association for Blood Conservation, Network for the Advancement of Transfusion Alternatives, NATA. Of course, it has a little bit of a different name now. It's a Network for the Advancement of Patient Blood Management, Hemostasis, and Thrombosis, but its origins were also really in this world of bloodless medicine and surgery, or transfusion alternatives. Other organizations around the world, the International Foundation for Patient Blood Management, more recently, a different type of organization, a foundation format, and many of these societies working together, working independently, collaborations, colleagues really trying to uncover much of this science, has resulted, as we know today, in hundreds and hundreds of peer-reviewed publications in medical, nursing, and other literature. A significant one, to me personally, that many of these folks were involved with, was the International Consensus Conference on Transfusion Outcomes. You can go look for that paper, certainly. But there was contribution from leaders in these regulatory agencies and elsewhere to really look at the outcomes of transfusion, this default procedure, in a very structured methodology. Very interesting paper, but I call that a turning point. There are many turning points, and we still have more points to turn, but lots of activity happening around the world in many medical societies. So going backwards and going forwards to the end here, that original methodology, those words are not used by Dr. Cooley or his colleagues, patient blood management. But really, if you think about the way he approached this and the focus on physiology, he really was describing what we now have as those three pillars of PBM: optimizing our patient's blood. Preoperatively, we recovered these many times, reducing blood loss and tolerating hemoglobin while we again support the body to regenerate this amazing organ. And fast forward again to where we are now with, of course, the World Health Organization having both the mandate and implementation guidance for why this should be the right thing for all patients. And again, at the heart of this was this pioneering mindset of Dr. Cooley and others, certainly, but we have hopefully a global momentum that will continue to grow away from the standard default transfusion practice. And really what happens in the blood bank is in the blood bank, but this is about the patient. So this is really the future of medicine with this personalized approach to this optimization. So just a couple of personal moments. I had the privilege of meeting Dr. Cooley when in 2003, the Society for the Advancement of Patient Blood Management gave him our President's Award. Also in that picture on the left is Dr. Richard Spence, who maybe we talk about more at a future Bloodless Medicine and Surgery Society meeting. He's been mentioned many times, of course, at this meeting over the years. Another grandfather of all of us, both of these gentlemen deceased, of course, and then, of course, a picture on the bottom right with Dr. Ari Shenner, my friend and colleague and partner for all these many years during that very nice meeting. So, finish this talk, I will play this video. I hope the sound works, but these are a few words from Dr. Cooley himself. Excuse me, in 2011, I shared with our friends, Dr. Axel Hoffman and Dr. Shannon Farmer. So let's see if this works.
Well, it seems to me that the surgical profession and the medical profession too has always felt that the blood transfusion was just a simple sort of a medication or a measure that had no side effects. But in those days, it was my impression that blood transfusion was another organ transplant, and that the same rejection factors affected the blood as a transplant as would if you had a kidney or a lung or liver transplant.
So during this wonderful interview, he actually was 92 years old, and he was still working 9 to 5 at the Texas Heart Institute. So an amazing man, and certainly a loss to the global medical and surgical community, but we will never forget his amazing work.
Well,
bloodless medicine and surgery. So he fundamentally altered the physiological landscape of modern surgery. He was an amazing pioneer in bloodless medicine and surgery, someone that we will always be grateful for, and it was my privilege to be able to share some of this history with you. Thank you.
Thank you so much for that, Sherry. That was wonderful. It was really nice to hear his voice as well. Well put together. Appreciate it so much. So it looks like what we will do, because of being short on time, is please any questions that you may have, put them into the chat. For Q&A, we will be happy to answer those in the chat, and we'll get to as many as we can for sure. We would like to just move forward. And
I think you still have a couple of minutes, Sandy.
Okay, in that case, what we'll do is introduce any panelists wishing to make a brief comment or to help answer questions. Anyone desiring to raise their hand can do so.
The question on platelet count, I think, should wait for tomorrow because there's a talk on thrombocytopenia. First talk tomorrow.
Okay.
And then there's a question for Dr. Refai. Says, thank you, Professor Majed Refai from David. My question is, in clinical practice, what strategies do you recommend to prevent transfusion-associated circulatory overload in high-risk patients, such as elderly or those with heart failure? I suppose it means other than avoiding transfusion entirely.
I mean, yes, I totally understand. Sometimes it's really needed, and sometimes you don't have any other option for it or no concentrated factor to use. What we used to do in these cases, if it's not really urgent, so we go slowly. We go with this transfusion over several hours, like up to 4 hours of a unit, or sometimes we split units and give them slowly over time. The other things we did and we can do and we did before is definitely if you can have the patient set up, that's number one. And second, give them some diuretics. So during the transfusion, you give them diuretics so you get rid of the water and just keep the proteins. We did this case in somebody who definitely needed plasma and cannot take prothrombic complex concentrate because there is some contraindication for these concentrated factors. They were not studied in the clinical trials and no clinical expertise with it, so there's a high risk of thrombosis. So in this case, you have to go back to FFP. In this case, we just gave them Lasix and within like a very short time, as you know, like a lot of people who use Lasix in their clinical practice, it does get rid of the fluids like really very fast. So that was an option, and ended up giving her 4 units. But with Lasix, she did not have any problems and no need even to further oxygenation.
Thank you for that, Dr. Rafai. So at this point, it is 21 after the hour. So in order to stay in a timely manner here, we will go ahead and thank Sherry again and your panel members. I'd like to take a moment and introduce Adrienne Korzenowski. She's an RN, and she will moderate the panel discussion on transfusion-free hematology involving patients and clinicians.
Well, thank you so much, Sandy. We want to welcome everyone to the panel discussion here with myself and then Dr. Usoro, the general surgeon and head of bloodless surgery unit in University of Calabar Teaching Hospital in Nigeria, and he is our co-moderator today.
Thank you, Idris. So I welcome everyone as well. Please carry on.
We're going to welcome we have a panel of patients from around the world today. We have Larry Richardson from Ohio in the U.S., Sarita Wright, Nasikan Idonset, Tina Vilches, Nurpress Chickener, and Dr. Essien, consultant of hematologist in the University of Calabar Teaching Hospital in Nigeria. So we're going to start with Larry Richardson and Tina. So, good morning, Larry, and this is your wife, Marcia, with us today. So can you tell us a little bit about yourself and the medical condition you have?
Okay. Well, I'm Larry. I'm 69 years old, and I was a steel worker. When I turned 60, I had a bout with arthritis, and that went away. And at 68, it came back, and I just it got really bad all of 2025. So I got to the point I couldn't talk, and I'm thinking, well, this isn't the arthritis. There's something else is wrong here. So we went to the hospital, and they found out that I had a low platelets, count. So,
Well, you told us some of the challenges you had, and that led you to the hospital. So when you came to the hospital, why did you choose to have bloodless care?
Okay. I chose the bloodless care. My wife is one of Jehovah's Witnesses, and I feel the same way she does about not taking blood.
Okay. And then how and where did you obtain bloodless care?
Okay. I received bloodless care at Toledo Hospital in Ohio.
And then how long have you had care for your condition without a blood transfusion?
Up to March 4th.
Okay. And when did you first get diagnosed?
The
emergency rooms.
emergency room
Okay.
at Toledo Hospital.
And that was in December of 25, right?
Yes.
Okay. And so how long or how many times, pardon me, have you been hospitalized for your low platelets?
Just one time.
Okay. Did you require any surgeries?
No.
Okay. And how did the doctors care for you without transfusing you with platelets?
I was given 4 infusions of
Rituximab.
and some iron, and I was
Prescribed prednisone.
Yeah.
Okay. And then are there any measures that you've done yourself to help minimize getting sick and help increasing your platelets?
Yes. I'm now eating food that supports platelets and production of not eating foods that make it hard for the platelets to grow.
Okay.
Put it that way.
Yeah. Hey, let's keep it simple, right? Do you have, first off, your platelets? How are they now?
They're doing really good. They're up there stable.
Right.
Yeah.
Normal. And then do you have any regrets about choosing bloodless care?
Not at all.
Good. And then are there any benefits that you see from having bloodless care?
Yes, I feel so much better now, and I can do more things, no bad side effects, and receiving a speedy recovery.
Great. It's wonderful to hear. And then do you have any final thoughts to share with the audience?
Yes, I'm thankful the option of bloodless care was there, and I feel I received the best care from the bloodless care team, and I can't thank them enough.
Well, thank you. We're so glad you had such a good experience.
Yeah.
So then we'll switch gears and we're going to go over and talk to Tina Vilches, the nurse practitioner that cared for you.
Okay. Thank you.
So Tina, can you tell us about your patient and the condition that he had and how you cared for him?
Yes. So Larry, like he said, he came into Toledo Emergency Department. He presented with weakness, fatigue. He had a petechiae rash on his lower extremities, and then he also was having aphasia. And the ED, they did imaging of his brain right away. He was found to have a 5 millimeter subdural hematoma. And of course, they were notified of his platelet count being 3 at that time, hemoglobin 12, and then, of course, he refuses blood products. So our team was consulted within about 2 hours of him being in the ED. We were consulted and notified pretty quickly of his low platelet count and that he was a bloodless care patient.
And then how do you feel when your patient told you, when he told you he didn't want a blood transfusion?
So our team, we had treated thrombocytopenia bloodless care patients in the past. So we felt pretty confident that we could treat him and that we could respect his wishes and we understood his concerns. So we just kind of got focused on figuring out the plan and possible diagnosis so we could start treatment right away.
And then what steps did you take to ensure that you could successfully care for him without blood?
So with thrombocytopenia, of course, we want to figure out as quickly as possible the cause. And so that involves, unfortunately, a lot of blood testing, checking his liver enzymes, checking to see if his bone marrow had what it needed to produce those platelets, like vitamins, B12, all of that. We checked for viruses and pretty much ruled out all the possibilities of causes. And then you're kind of left with ITP, or your immune system destroying those platelets. Once we came to that conclusion pretty quickly, we started high-dose steroids, 1,000 milligrams of Solu-Medrol daily, and we started IVIG. And we had discussed possibly using PCC because of the subdural hematoma, but his liver enzymes are fine. His fibrinogen, all of his clotting factors that we had checked were fine. So we held off on that. He was in the hospital only, 4 days. He was there and he was discharged. And within the first day, so platelet count started off 3. The next day we checked it after treatment, he was already up to 23. By the time he was discharged, he was around 60. And then we had given him his first dose of Rituxan while he was in the hospital. And then we continued treatment of that, gave him 4 more doses, monitored platelet count pretty closely outpatient. And then now currently his platelets have been consistently 200. So.
Great. So he had a good outcome with the treatment you provided him. And then do you have any regrets with caring for this bloodless care patient?
No, of course. It kind of reinforces the care that we give here at our bloodless care hospital, on our team. It reinforces that you can treat patients without blood successfully. So no regrets.
Oh, great. Any final thoughts, Tina, that you'd like to share?
No, but if anyone has questions, you can always email us or send us whatever questions you have.
Great. Thank you so much, Tina. And thank you, Larry. So I'm going to turn it over to Nathaniel.
Yeah, let me add my voice to say thank you very much to Larry and Tina. That was fantastic. I suppose we will hear more about thrombocytopenia tomorrow when Dr. Mark Friedman will be talking on that. So for now, let's listen to our favorite warrior, Sarita. Welcome, Sarita.
Well, thank you. Thank you so much for having me.
We were blown away by your presentation on Tuesday, was it?
I turned off the camera, so you don't have to.
This is
and you're
another
muted.
chance now to hear from you. So
you have to unmute. There you go.
oh, I'm so sorry.
It's okay.
So thank you so much. We were blown away by your presentation on Tuesday, was it? Anyway,
Wednesday.
it was on Wednesday, right? So this is another opportunity to hear from you, and we're very happy that we have you here. I don't know at what point that microphone got muted. Did my thanks to Larry and Tina get out there?
Yes.
Oh, okay. So I wasn't the one who muted it. Maybe it's technology. Anyway, so this is another chance for us to hear from you, Sarita. Tell us about yourself a bit and about your medical condition.
Well, I am 43 years old, living with sickle cell beta thalassemia 0. And I've had hypoxemia as a result of just the progression of this disease.
So that's a combination of two entities. There's a sickle cell and there's also thalassemia, both
Yes.
of them inside of you. Wow. So what are the challenges that you have faced with this condition?
I have chronic low oxygen, chronic anemia, chronic fatigue, um, and both chronic and acute pain episodes.
I can imagine sickle cell, thalassemia. So why did you choose to have bloodless care?
Well, I've always been a student, and then I was raised by very education forward thinking parents that, always taught us to investigate. So when I first had my first introduction about blood was in the Bible, that it said to abstain from blood. So as a Bible student, I understood that part. But then as I dig deeper, I wanted to know why. So I became a student of transfusion medicine and bloodless medicine, and I wanted to compare it because every time I got sick, I had to be firm on my resolve. And it was always going to be a question as to, like, are you sure? Are you sure? So I wanted to know my facts so that I could say definitively, yeah, I'm sure, no blood.
Many people here might not understand how good a student you've been, but I do because I've attended one of your webinars in which I actually thought you were a medical doctor when you were talking about the pathology of your problem. So how and where did you obtain bloodless care?
So I've had it all my life. So I've gone to different facilities, and I've lived in both Alabama, I've lived in Philadelphia hospitals and surrounding areas, and I've had a lot of different exposures to advocating for bloodless medicine because I did not know about the facilities that were designated for bloodless medicine until I was clearer into my adult years. So I did have an occasion where under Children's Hospital, they forced a blood transfusion on me against my parents' wishes. And what I've come to learn as an adult was that the fact that I have my hypoxia was connected to that original transfusion.
And I know you've had a lot of care from Dr. Ford. Her team were here. That's Carrie and Jen who spoke. Was it yesterday? I get
Yes.
confused about the days. So they spoke about stem cell transplant without blood transfusion. So, but I would like to know, how long have you had care for your condition without blood transfusion? How many months or years have you been able to stay without transfusion? I know about the forced transfusion when you were a child.
Yeah, so usually I'm probably coming up on 39 years where I have had no transfusion at all whatsoever.
Wow, that is something. So that's a testimony to the good care you've been having and also to your will, because you're the one that asked for that care. So it's in excess of 30 years. How long did you say? 30 what?
39.
39 years. That's almost 40 years without
Yeah.
blood transfusion. And how many times have you been hospitalized for your medical condition over this period? Have you had any bloodless surgeries?
Yeah, I've had several bloodless surgeries. I've had to have my gallbladder removed. I've had my thyroid cancer back in 2016, so they had to do two surgeries to remove my thyroid because they had to confirm that it was cancer, and then when they did see that it was malignant, then they had to go in twice. And I've had, other minor procedures, but for the most part, um, I've been hospitalized probably 25 times in my lifetime dealing with this illness.
This is amazing. You've had major surgery as a patient with sickle cell plus thalassemia without transfusion. So did you stay for ages in hospital because of the surgeries? because you didn't take a transfusion.
And that was always the biggest part. I would be like, after my thyroid cancer surgery, they discharged me the next day. I had
Wow.
like one day. And then after the gallbladder, that was a 3-day hospital stint. So I did have faster recovery times. The longest I've been in the hospital, even with the sickle cell crisis, was usually about a week. But the average time was 5 days, and I would be able to be discharged within 4 to 5 days.
Amazing. So there are actually superior outcomes from bloodless surgery. But how did your doctors care for you without blood transfusion? Any idea?
Yeah, so our routine was to automatically put me on IV fluids. They would check my iron levels and give me IV iron. I would get a shot of the EPO, where it was Procrit, or now I'm on Retacrit. And it we just kind of did that routine. And I would explain to them, like, that plus pain management, because you definitely have to address the pain in order for me to be able to calm down. Because a big part of sickle cell is when you're in pain, like, you have to be able to relax your body in order for your blood vessels to finally open up so blood flow can happen. And so that was the routine, like clockwork.
Right. So Dr. Ford had intended to be with us, but unfortunately she couldn't join us. She would have said more on this. Are there any measures you yourself have been taking to minimize your chances of falling sick or having a low hemoglobin?
Yes. So what I had to do is shift from being episodic and reactive to sickle cell, and I had to become more proactive in how I lived my life. So I had to make some dietary changes. I had to start eating specific things that I know could help boost my blood, drinking specific things. Like I make my own juices now, my own teas, and like reduce my sugar intake. I stopped drinking alcohol, all the things that were putting me at risk, especially in my 20s, was my biggest time period where I kept getting sick, but I was trying to be like my friends. I'm drinking like my friends, and I couldn't understand why I needed to move differently. And so now that I'm being more conscious of what I'm putting in my body, I'm noticing the change. And then I go in once a month and I get the Retacrit EPO shot just to keep maintaining my hemoglobin, because my baseline is around 7.5. And
Right,
so
right,
the
right.
highest it might get to, it could be 8, but I live right in the 7s.
Thank you so much. Do you have any regrets for choosing bloodless medicine?
Absolutely not. One thing that I found out as I started listening to other warrior stories and the things that they've had to contend with their chronic blood transfusions, was that it was making them sicker, and that part kind of hurt to hear. I did not want that. I don't want it for me, and I don't want it for them. So that's what even made me create my nonprofit organization, of just being able to share the fact that bloodless medicine should be an option for all sickle cell warriors, because it truly has been superior in how we're being treated. I have fewer infections, shorter hospital stays. I'm able to thrive and do more things, where living with intention instead of kind of just going with the flow of the protocols for treating sickle cell.
That is just wonderful. So you've encapsulated the benefits of bloodless medicine. And we're so thankful that you kept up the fight as a warrior, and you're inspiring other warriors. I remember their last webinar, someone actually attended from Nigeria, uh, another sickle cell warrior. And I'm sure
Mercy.
there are many others around the world.
Yes.
So thank you so much, Sarita. I don't know whether Adrian had any other question for Sarita.
No, that was wonderful. Thank you.
Thank you.
Thank you. Over to you, Adrian.
Okay, so I'm going to talk with our next person, Ms. Sikan. Thank you for joining us this morning. But can you tell us a little bit about yourself and the medical condition you have?
Hello, everyone. Good afternoon. It's afternoon here in Nigeria, so good afternoon from here. My name is Nsikan Idoeset, as you already know. I work as a broadcast journalist and also I live with HBSS.
What challenges have you faced with this condition?
Well, besides the frequent pain sometimes, and also stress and then fatigue, I think one of my major challenges has to do with stigmatization. I face a lot of stigma, especially when people get to know that, okay, this person is living with, or she's a sickle cell warrior. So many people tend to see you as incapable of doing something great because they think you're fragile, because they think you're okay, your fate, you're just doomed to die and all of that. So they see you as a weakling and lack the ability to grow beyond the surface. Hence, they deprive you of some kind of opportunities like job opportunities, career growth, and the likes.
Oh, wow, well, thank you for sharing that. Why did you choose bloodless care to have bloodless care, and where did you obtain it?
Okay, as one of Jehovah's Witnesses, my belief does not support blood transfusion. Also, blood transfusion doesn't guarantee a healthy life. The doctors at the hematology unit here in the University of Calabar Teaching Hospital have actually supported me on my journey of bloodless care.
And how long of this journey without blood transfusions
I'll
have
say
you been?
30 years. 30
Wow.
years.
Wow. Now, how many times have you been hospitalized for this condition? And have you had to have any bloodless surgeries?
Okay, I have not had any surgeries so far. I've not had any surgeries. And I would say I've actually not really spent more time in the hospitals from my growing up or from when I was diagnosed, which I was 15 then, when I was diagnosed of being a warrior. I'd say from that period till now, it's 10 times or less. So I'm one person
Wow.
who, yes, wow, I get that a lot.
That is impressive.
Okay.
So, how do your doctors care for you so well
Um,
without transfusion?
Well, my doctors actually do a great work just to make sure that I stay off the hospital because they know I do not like the hospitals, sincerely. So they actually do great works. First of all, they actually support me on my blood stance by prescribing medications such as the EPO, as when they notice that, okay, my blood level is really low, and place me on, of course, I take my folic acid and other blood boosting tonics as well, take my veggies as well. This helps me to, take my vitamins and it helps me build my own blood.
Yeah. So, are there any more measures that you take to minimize your chances of having
Yeah.
to be in the hospital?
Yes, they are. Knowing my triggers, number one, I tend to understand that, okay, excessive stress can actually make me break down. And also, I make sure I avoid crowded places because I know whereby if I'm exposed to many people, I could come in contact with some infections. And these are the major things that takes me to the hospital. So when I try to avoid crowded areas. And in as much as, okay, maybe my job sometimes can make me go out, I tend to put on maybe a face mask or nose mask just to help me prevent any sort of infections. Then I'm actually big on hydration. I take lots of water and I also take my vitamins necessarily, take my fruits, green vegetables, and I've also been placed on hydroxyurea. So I take that daily and carry out little exercise, not the intense one, so that I don't break down. And then I stay happy and positive at all times because once the mind is sick, it actually affects the brain and affects the whole body. So I don't like putting what I go through in front of me, but rather I try to work with it to make me happy and I stay positive.
Wow, that's an excellent example to do
Thank you.
that. Do you have any regrets for choosing bloodless care?
No, I do not have any regret at all.
Okay. And then how has your hemoglobin been lately? Has it been steady?
Well, last time I went to check, my steady state is always 25% hemoglobin. So sometimes it could go up by 2, but the steady state is always 25.
Okay. And are there any benefits that you've personally experienced with bloodless care?
Yes, there are lots, but I'll just mention a few. First of all, I know if for not taking transfusion, avoid the risk of getting infection. There's no risk of infection at all. Also, sometimes it's because most of these things are being overlooked, especially during screening. All they just get to know is, okay, this blood matches your blood type, so this can go. So they overlook the infection part of it. Also, another benefit I would say I have gotten is that my body gets to build its own blood and it is not dependent on someone else's. So yes, these are just few benefits I could talk about.
Yeah, thank you. And are there any other final thoughts you'd like to share with us?
Well, I just want to say, Major, first of all, I want to talk to the doctors. I want to say big thank you so much to the doctors, to the nurses, to the healthcare providers that put on the work and, work tirelessly to protect and save lives. Also, thank you to the Bloodless Medicine Department who have been carrying out different studies and research just to make sure that our life is not dependent on blood transfusion. And also to all the warriors out there, sickle cell warriors out there, I always say you can live and thrive beyond the surface. You can do great things if you do not shrink because of how people label you. So, yes, these are my few words.
Wow, thank you so much, Ms. Kim. That was wonderful. So let's switch over and talk to your provider, Dr. Essian. Dr. Essian, can you tell us a little bit more about her condition and how the care you provided her?
So, Sikaka said earlier, she's a sickle cell patient. She has sickle cell anemia, which is the severe form of the hemoglobinopathy. And she presented in a state that was almost similar to, more like anemic heart failure when she presented with vaso-occlusive crisis. We know she's a Jehovah's Witness and therefore did not want blood. So we had that understanding. It was documented and there was a consent form signed and everybody was in the understanding. So we admitted and we started with oxygenation just to oxygenate her. She was given oxygen. And we now calculated the deficit. We had there's a scoring, a calculation that you do with iron sucrose, with iron, if you want to replenish iron. And so we did that and we had a targeted hemoglobin that we wanted. Her study state is 25. I think she came in a hemoglobin level of, I think 6 grams per DL, and that was 18%. So we needed to optimize her to get out of that phase. So we started with the iron supplementation, intravenous, and erythropoietin, but we were careful to monitor her vital signs, her oxygen saturation, and then the pulse rate. So we needed to know if there's any downward trend. We were trying to be proactive, knowing that she did not need blood. So we were not waiting for when it's become an emergency. So we started the optimization immediately. And we started also, since she was having a vaso-occlusive crisis, we started with the analgesia and fluid, needed fluid. But we were careful with fluid at that time because of the anemia that she had. We didn't want to dilute what she had, and so we're a little bit careful. But however, Sika did it was remarkable. The recovery was fast. She built up the PCV. She stayed like, I think, 4 days on admission. And by the time she was leaving, the hematocrit had appreciated much. She was off oxygen and she was pain-free. We discharged her, but she kept on coming for checkup and she's doing well. So the recovery was very fast.
Well, that's great. So how did you feel when you first saw her as a patient and found out she didn't want blood transfusions? We might be frozen for a moment. We might have lost her here.
While she's trying to come back, I think I could give you an idea what she told me.
Okay.
So she said that she was completely at home with the treatment because they already had the bloodless orientation. They knew they take care of patients in an ethical manner, and they knew how to raise the hematocrit. I wish you were here because I wanted to say many doctors would be scandalized to hear that she gave IV iron to a sickle cell patient. But it is the right thing to do because even though sickle cell patients may have iron but sequestrated, and so those same doctors who wouldn't give IV iron to a sickle cell patient will not hesitate to give blood transfusion, whereas each unit of blood has 200 milligrams of iron. Okay, Dr. Sian, it's good you're back. You are being asked how you felt when your patient said, I don't want a blood transfusion, and she's a sickle cell patient.
Well, I'm used to having a lot of sickle cell patients telling me they don't want blood transfusion, so it's nothing new, it's nothing strange. So I have to learn to accept, and we generally in the department accept them that way. If you tell me you don't want blood transfusion, that's your choice.
We're having a poor connection today.
Yeah, yes, I think she's in her
the clinical approved and ethically approved way that. Hello?
Yes,
we
go
can hear
ahead.
you
You
now.
went off for a while, but you're back. Welcome.
Okay, thank you. So that's what we do. So I wasn't afraid. We weren't shy. I wasn't shocked. We have a lot of sickle cell warriors that tell us we don't want blood transfusion. We'll ever cancel you, but when you insist that you don't want the blood transfusion, we respect your preference way and we optimize you the way we can do.
And do you have any regrets for doing bloodless care for Nisakan?
No, I don't have any regret. My patient is alive and well, so I don't have any regrets. She left the hospital at a recorded time, and so she's doing well, so I don't have any regrets.
Wonderful. And do you have any other thoughts? Because you covered her case beautifully. Do you have any other thoughts that you'd like to share with the audience today?
So my thoughts are, as clinicians, we shouldn't be eager to discard patients that say they don't want blood transfusion and label them. I think the bloodless medicine gives us an opportunity to learn an alternative way of raising the hematocrit for our patients. You just cancel them, which you need to do, and you put the route that they want. So there's nothing there. Patients do well, they recover. A sickle cell patient is believed some tend to have reticulocytosis, so the marrow is responding. So it's just to manage and keep them alive while the marrow takes over and the blood cells are built. So I don't have any regrets. So I want clinicians to embrace the bloodless medicine, and not necessarily because you're a Jehovah's Witness, but you might have a patient, one or two, that says, I don't want blood. You should be able to know what to do for that patient and not just to push the person away. Thank you.
Yeah, that's a wonderful thought and good advice for clinicians. Thank you so much to both of you ladies. This was a wonderful interview and learned a lot from it.
Thank you very much, Nsikan, and also Dr. Sen. That was great. So Larry's wife is Jehovah's Witness. Sarita was raised Jehovah's Witness, and I believe she is Jehovah's Witness. Nsikan is Jehovah's Witness. What about a sickle cell patient who is not Jehovah's Witness? There's such individuals that wish to have bloodless care. So I'd like us to listen to Debbie. Debbie is a member of staff in my hospital, and she has a few things to say. Incidentally, many of these patients who have bloodless care have sickle cell disease, don't look like they have sickle cell disease, and I never knew that some of them were sickle cell patients. So let's listen.
We can't hear the sound.
Oh, I'm sorry. I apologize. You're going to hear it now.
Hello, everyone. My name is Debbie, and I work with the University of Calabar Teaching Hospital as a senior administrative officer. I've had 2 cesarean sessions and 1 bilateral hip replacement, all without blood transfusion, and I also have sickle cell anemia. Now, I am not a Jehovah's Witness, but I'm a bit skeptical about blood transfusions because of the risk involved in it, no risk of infections and all that. So I actually chose bloodless surgery. Now, my first surgery was a cesarean section, and that was in 2009, where my obstetrician referred me to the bloodless surgery unit because I told him I wouldn't want a blood transfusion. And so when I got to the bloodless surgery unit, I was taken care of, and they made sure during the surgery I was warm, I had enough fluids, and I had oxygen briefly by the face mask. And so I went into theater with a PCV of 35%. Okay. And lest I forget, before surgery, I had an 18% PCV. And so I had to build up with diets until I got 35%. That's when I went into surgery. And I came out with a PCV of, after surgery, I came out with a PCV of 9%. And I wasn't transfused. Now, 5 days after the surgery, as post-OP, I was discharged to go home without any complications with a PCV of 25%. And of course, I continued at home building up with diets. Now, the second surgery was an emergency cesarean session, and that was in 2016. I went in with a PCV of 28%, and I was discharged 7 days after the surgery with a PCV of 27%. And I was only given 1 shot of erythropoietin and asked to build up with diet, which was my choice. The third surgery was October 2020, and that was an emergency bilateral hip and partial hip replacement. So I went in with a PCV of 25%, and I came out safely. My discharge was a bit delayed because of the excessive bleeding from the OP site. But 5 weeks after that, I was fine, and I was sent home with a PCV of 28%, raised strictly with diet, no transfusions at all. So really, I'm glad I chose bloodless surgery. I have no regrets about it, and I still maintain my normal packed cell volume, and I'm a very healthy person. Thank you very much.
Well, you heard it from Debbie. Debbie gives us another thing, another shocker. She routinely raises her own PCV to as high as 35 with diet, and her hematologist tell her stop. But she doesn't have any untoward incidents from having that high PCV. So evidently, without blood transfusion, it may be, we need to look into it. It might be safe for sicklers to have higher PCV because maybe they're just having normal blood inside of them without antibodies. Yeah, so Adrienne, over to you, please.
Well, thank you to everyone, all of our patients and providers. I think this was a wonderful panel discussion. I know I learned a lot about especially sickle cell with hemoglobin, treating sickle cell without blood transfusions. So thank you once again, and I'm going to turn it back over to Sandy and Tony to close out our morning.
Thank you, Adrienne. Thank you, Dr. Nathaniel, all our panelists. We had such a wonderful response to the ones that were interviewed today. Team Richardson, Debbie, and Siken, you all did such a wonderful job. Sairita, inspiring us just to show that the strength it takes to be your own warrior, but also just to stay true to your values and see that it can be done. We have probably, well, we know we have countless others that can share their stories yet similar to yours. So thank you for that. We want to go ahead at this time and just share tomorrow's schedule. And that is the 6th day of our conference. Tomorrow is also World Bloodless Surgery Day, very big deal for us. So we're very excited about that. We're going to have a few presentations, thrombocytopenia, causes and management without transfusion. That'll be by Dr. Mark Friedman. Also, our big World Bloodless Surgery Day lecture by Dr. Mohammed Biden. This would be bloodless surgery, refining surgical excellence. So we look so forward to that. We will also have our test, our quiz, as well for bloodless medicine and surgery basics. So we look forward to that, our final day. At this time, we also want to call for a group photo. So all panelists, please turn on your cameras and give us a moment so we can capture our picture.
Sarah, please tell us when to smile. You know I don't smile all the time.
Smile. Done.
Okay, we got it?
Yes.
One more person is doing that. Okay. Blessing, have you got it? Okay. Oh, okay. All right. No worries. I think
got
we're
it.
okay with. Okay, Sarah has got it. That's fine. All right.
Great. Okay. So at this point, again, thank you to everyone. These last 5 days have been just so fabulously inspiring and excellent and informative. So we'll see everyone tomorrow at the same time. Dr. Usoro, you have anything else you'd like to add before we close?
Oh, just to say a big thank you to all speakers, moderators, panelists, attendees, and to wish you a very happy World Bloodless Surgery Day in advance against tomorrow. And to beg for, the person I'm begging, I didn't even thank her. Sarah, thank you so much. So I wanted to beg her to also help us with some more music because she was good yesterday.
Okay.
And yeah, so thank you very much and bye-bye, everyone.
Take care. See you tomorrow.